My name's Chris Hardy. I'm a urologist in Newcastle in the UK, and I've got a clinical and an academic interest in urinary tract infections. I'm going to talk to you this morning about non-antibiotic options for UTI prevention. So there are my disclosures. So the reason why non-antibiotic options are so important is because of antimicrobial resistance, and the top part of this slide illustrates how the usage of a particular class of antibiotics, in this case fluoroquinolones, which includes ciprofloxacin, can be quite closely mapped to subsequent antimicrobial resistance. The graph on the bottom actually echoes something that Bhaskar just demonstrated in the last decade, which is an increase in antimicrobial resistance across the vast majority of antibiotic agents. The one antibiotic that seems to escape this increase in antimicrobial resistance is nitrofurantoin. So it absolutely supports what you've just heard from Bhaskar. This is some data from my colleague Zafar Tandogdu, who will be speaking later, and it's from the global prevalence of infections in urology study, and it's particularly, this graph is looking at hospital-acquired urinary tract infections, and you can see the high levels of antimicrobial resistance across all antibiotic agents and across all of the continents. That is true. And I was also talking about the gold standard treatment, or the most recommended treatment for prophylaxis, being daily low dose antibiotics. And I want you to remember the relative risk quoted here, which is 0.18, and you can use that to compare when I show you the other non-antimicrobial options. So it's not just me that thinks this is an important issue, it's also the World Economic Forum, which looks at global risks and have listed antibiotic resistant bacteria as big of a risk as a global pandemic. And I think 2020 has taught us the impact of that. So I'm going to talk about contemporary management in terms of UTI prevention. And as you can see, there are probably more options than you may think, and I'll address the data pertaining to those individual treatment options as we go. So the first one is fluid intake. We've been telling patients for a very long time to increase their daily fluid intake without much evidence to support that recommendation. But a couple of years ago in JAMA, there was an RCT of 140 women which was published. They all had recurrent UTIs and they all had poor oral intake. Now that just wasn't self-reported poor oral intake, that was a high urine osmolality and a low urine output on screening. They were randomized to take an additional 1.5 liters of fluid intake per day versus no additional oral intake. And as you can see, if you look at the number of cystitis episodes in both the control group and the water group, there's definitely a left shift in terms of number of UTI episodes suffered when patients drank an additional 1.5 liters of water. Numerically, that's a reduction from 3.2 episodes to 1.7 episodes in the follow-up period, which is associated with a risk reduction of 0.47. It's also associated with a reduction in the number of antibiotic courses needed. So we now have level 1 evidence to support our recommendation to patients that increasing fluid intake will reduce UTI episodes. Cranberry products are another non-antibiotic treatment option that a lot of patients like because their relative risk is low and their number of adverse events is small. They work probably by acidifying the urine, and they perhaps also are able to reduce the adherence of bacteria to the urothelium, maybe by preventing expression of fimbriae, which are these filamentous organelles found on the edge, particularly of uropathogenic bacteria like E. coli. So the evidence for cranberry is a little bit controversial. And okay, so we talked about the need for non-antibiotic treatment. We talked about fluid restriction being an evidence-based treatment. Now we moved on to cranberry and told you about the differing conclusions from the Cochrane reviews over time. Since the last Cochrane review on cranberry products, we have had some reasonably high quality studies, and a couple of them I've detailed here. There was a meta-analysis in 2017 which described a risk reduction of 0.67, so that's nowhere near the kind of risk reductions we've seen with daily antibiotics. And again, it's quite consistent across the various studies. There is a slight improvement in terms of risk reduction in the study that I've quoted at the bottom of the slide, which looks at combination therapy with cranberry and a substance called propolis, which is a naturally occurring substance which bees make to wall off certain areas of their hive. So that's one particularly novel study involving cranberry products, but as you can see, the reduction in risk of UTIs is not of the same order of magnitude as we would expect from, say, daily antibiotics. So we'll move on to topical estrogens. Now, as you know, reduction in estrogen levels lead to changes in the vaginal flora and also a change in the vaginal pH. It becomes less acidic as estrogen levels fall. And you can get reversal of these changes by the use of local estrogens and the fact that they have a risk reduction of 0.25, which is comparable to daily antibiotics. Methenamine is what I would call a urinary antiseptic. It has antibacterial properties following its hydrolysis to formaldehyde in the distal tubules of the kidney. It has also been the subject of a systematic review published by the Cochrane collaboration, and a risk reduction in UTI episodes of 0.24 was documented. There was some questions from that review that it may be ineffective in patients with neuropathic bladders or abnormalities of their renal tracts, and the Cochrane review concluded that there was a need for a large, well-conducted RCT. So we did one, and this is the ALTA trial. It's daily antibiotics versus methenamine hippurate over a 12-month period for women who suffer with recurrent uncomplicated urinary tract infections. The primary outcome is UTI incidence, and the trial has just concluded and is being written up, so will be published hopefully in a major journal quite soon. In terms of vaccines, there's an excellent systematic review which Basker's group have done, looking at 17 studies with over 3,000 patients, and reports both good short and long-term reductions in UTI. And again, the risk reduction of 0.17 in the short term and 0.2 in the longer term has been documented. What's very interesting about this review is that it also documents a fairly low rate of adverse events. This is the forest plot detailing that the vast majority of studies on vaccines give a beneficial effect in favor of the vaccine. The most commonly studied vaccines are Urovaxum, which is the only one that's ever been recommended by the EAU. Some of the most widely studied vaccines, the first one is Urovaxum, which is oral administration, 18 E. coli strains. You can see on the forest plot there that there's a big swing to the left in favor of the oral vaccine. There's a vaginal vaccine called Urovac, which again reduces UTI recurrence, but not by as much. And then there's a newer agent called Uromune, which is an under-the-tongue spray, which is currently undergoing trials both in Spain and the UK. So I'll have the next slide, please. So Uromune is a multivalent bacterial vaccine. It's not just E. coli, it's got Klebsiella, Proteus, and Enterococcus. It's basically about 10 to the 9 inactivated bacteria per mil, and it's used submucosally in the oral cavity to give a widespread lymphogenic response. So I'll have the next slide, please. It was first published in 2012. Next slide. And it's an observational retrospective study. So the evidence is not the high level evidence we've talked about previously in Cochrane's systematic reviews, merely a retrospective study, but good numbers of patients, about 160 in each arm. One arm was randomized to given Uromune. The other arm was given a combination of trimethoprim and sulfamethoxazole. Next slide, please. So as you can see, the preoperative UTI rates were similar in the two groups, but then there's a big gap between those given Uroimmune and those given prophylactic antibiotics. So this is, in conclusion, a very promising treatment. The evidence that I'm presenting here is quite low level, but I'd very much like to see a randomized controlled trial looking at Uroimmune because I think it's a promising vaccine treatment. Next slide, please. I'll now move on to intravesical treatments. So there are some non-antibiotic intravesical treatments, and these are generally centered around the replacement of the glycosaminoglycan layer in the bladder, which is one of the first lines of defense to try and prevent bacterial adhesion to the urothelium. There's various different agents available. And there are some systematic reviews which have been published, and they demonstrate reduction in UTI frequency, reduction in symptoms such as pelvic pain, but there are some limitations, and I think further studies are needed. You can see from the forest plot on the bottom of this slide that the decrease in UTI infection frequency is really quite dramatic, but I think a lot of these studies are quite small, and I'd quite like to see them reproduced on a larger scale. Next slide, please. Bacterial adhesion inhibitors are probably one of the future directions in terms of UTI prevention in a non-antibiotic way. And one of the ways of stopping bacteria from adhering to the urothelium is to block the terminal subunit on the fimbria, which is known as the FimH subunit. And you can see that colored pink on the screen there. That FimH subunit normally binds to monosylated residues on the urothelium, and that's the first stage in bacterial adhesions. If we can prevent that process with a compound such as a mannoside, which will sit on the FimH subunit and block it, you may result in less UTIs because of less adherence of uropathogenic bacteria. Next slide, please. One such compound which works by this mechanism is D-mannose. It's a naturally occurring sugar, and it prevents the binding of uropathogenic E. coli because it competitively antagonizes the fimbrial H subunit. The best evidence is a single RCT, 308 women who were randomized to 3 arms, daily nitrofurantoin, D-mannose at a dose of 1 gram twice daily, or no prophylaxis at all. And as you can see, a risk reduction of 0.24 is associated with the D-mannose treatment. So that's comparable to some of the previous non-antibiotic options I've detailed. Next slide, please. And again, Basker's group did a really useful systematic review on the subject of D-mannose and concluded that it significantly reduced recurrent UTIs in both catheterized and non-catheterized patients. And this is 6 trials with around 700 patients. And they also said that it was effective in reducing the incidence of recurrent UTIs and prolonging UTI-free periods, which obviously had a sequelae of increasing quality of life. So reasonable evidence to support the use of D-mannose. Next slide, please. Probiotics. Now, there are several different ways of using probiotics to prevent urinary tract infections, and the reason why we use them is because urinary tract infections are often preceded by the presence of pathogenic bacteria in either the vagina or the periurethral area, and the aim is to try and normalize the microflora of the vagina and periurethral area by directly giving probiotics. A couple of possible mechanisms are that you can inoculate asymptomatic bacteriuria strains of E. coli into the bladder. That's not very commonly done. You could use commensal lactobacilli in the vagina to out-colonize the E. coli. That's, again, not commonly done. The most common way is to use oral probiotics to try and displace the pathogenic E. coli within the gut. Next slide, please. In terms of the evidence, there's a randomized study of 100 women with recurrent UTIs. They were randomized to a probiotic, which in this case was Lactin V, or placebo daily for 5 days and then once a week for 10 weeks. They not only took urine samples looking for urinary tract infections, but they also took vaginal swabs, specifically looking for RNA belonging to lactobacilli, because the idea is that if you give the probiotics, vagina will become preferentially colonized with lactobacilli. Next slide, please. So the results showed that the UTI rate almost halved in those who were receiving the probiotic, and this is a relative risk of about 0.5. There was also high level vaginal colonization with lactobacilli in the probiotic arm, and this again correlated very well with reductions in UTI. So that confirms not only the clinical utility of this treatment, but also the proposed mechanism. Next slide, please. Something that may emerge, bacteriophages. They are intracellular viruses that infect and kill bacteria. They were reported a long time ago, but following the discovery of antibiotics, interest in bacteriophages kind of waned, but now we are running out of antibiotic options. This may be something that future research looks at. These are part of the innate immune system. We all have these phages within us. Next slide, please. So what happens is that the phage DNA is injected into the host cell, in this case a bacteria, and it can destroy the genome or be incorporated into the genome. And these are kind of modified virulence phages, which are generally used for therapy. What tends to happen is there's a cocktail of different types of phages which are used in clinical practice. But again, this is something that will certainly require further research, but it's one area that I think is quite exciting. Next slide, please. There is an RCT, which is men who are undergoing prostate surgery with positive urine cultures preoperatively. It's a 3-arm trial. It's a commercial bacteriophage versus an antibiotic prophylaxis versus placebo, and the primary outcome is the clearance of bacteriuria. And the protocol was published in BMC in 2017, and the results are awaited. Next slide, please. So in conclusion, there are a couple of reviews to highlight if you want to look at this topic further. The first one is something that Rajan and myself wrote for the BMJ a couple of years back, and this reviews only high-level evidence on non-antibiotic treatment of recurrent UTIs, but it does also include some research recommendations. And the next slide, please. And then there's a more comprehensive review from the group at Guy's Hospital in London, which I cannot recommend highly enough. This is a really nice review article. It's quite long, but it's so informative, and it's a thorough, detailed analysis of the existing literature on recurrent UTI prevention. Next slide. So we have finally got to the end of this talk after several tries, and I'd like to conclude. I hope you have taken away from this talk that recurrent UTI is a very prevalent condition. We are now looking towards non-antibiotic treatments as they are preferable in the antimicrobial resistance era. I've hopefully outlined the evidence to support a plethora of non-antibiotic options for you, but there are in several areas good quality RCTs are needed. There are lots of new non-antibiotic treatments on the horizon, but these should be evaluated thoroughly. And I'd just make a plea to anyone who's researching in this area, as the control arm of their study, they need to probably use daily antibiotics. I think that's a really good methodological piece of advice. So I'll finish there with the next slide, just to acknowledge the people who have stimulated my interest in recurrent UTIs and helped me along the way in my career. Thank you very much for persevering with me.